Good. Now let's get into the game, okay? Because tonight you have another class. So let's get into the game. So we are dealing with the free practice questions, and we are dealing with, I think, question 9. And this is another ethics question. And, if you know the distribution of the questions, I have a whole YouTube video on how the Medical Council of Canada distributes questions. It will help you to really appreciate how you need to prepare very well for this exam. But I'm going to give you this question. It says, and this is from the Medical Council of Canada on their free question website, right? So it says that you have a 28-year-old man who presents to your clinic for follow-up. He had a humerus fracture and experienced profound radial neuropraxia after surgical intervention. You have been monitoring his recovery for 3 months. Today, due to ongoing symptoms, the patient expresses dissatisfaction with your care and threatens to take legal action against you. Which one of the following is the best next step? Which one of the following is the best next step? So this is a patient you dealt with, had a humeral fracture, and now the patient is experiencing a lot of pain, neuropraxia, right? And then the patient says, look, I'm going to take a legal action against you as a doctor. What is your next best step? Remember that I always tell you that. So this looks like the Medical Council is combining orthopedics, neurology, and ethics. So like the ethical concepts, from what I'm seeing from the free questions, always come in a context, right? So it's not enough to say I've learned neuropraxia, because neuropraxia comes under pain. There's a whole objective on pain. There's a whole objective on bone and bony deformities. So that is where humeral fractures come. So now look at the way they've combined 3 different objectives: an ethical objective, a pain objective, and then an MSK or orthopedic objective, right? So what will you tell the patient? A, tell the patient to direct his concerns to the local medical regulatory authority. Number 2, B, express your regret and explore the patient's concerns. C, reassure the patient that his symptoms will eventually resolve. And D, offer to immediately transfer the patient's care to a colleague. So what do you do if, like, maybe you've performed the procedure on a patient and the patient is angry because the procedure did not go, or the recovery is not going as the patient wants? This is the kind of question you should be expecting in your board exam, right? Very practical question. And what is the correct answer? The correct answer is B. You've got to express your regret and explore the patient's concerns. Because tell the patient to direct his concerns to the local medical regulatory authority. It looks like somehow it looks like you are just brushing the patient off. And also reassure the patient that his symptoms will eventually resolve. It looks like you are downplaying the patient's concern, right? And then offer to immediately transfer the patient care to a colleague. Not so good. So let's get into what the Medical Council itself said. It said that the most appropriate initial response is to express regret and explore the patient's concerns. Okay? And this, why should you choose this approach? Because it demonstrates empathy and willingness to understand the patient's perspective, which can help to de-escalate the situation. You remember, in this whole medical practice we are in, we want to make sure that we are putting the patient first. At the same time, we also want to learn skills to learn how to de-escalate patient situations which are going out of hand, right? And can also potentially resolve the patient's dissatisfaction. Because when you take your time to listen to the patient, it helps you to appreciate where the patient is coming from. And as well, this response also aligns with professional standards of patient care, which emphasize communication and patient-centered care. So that is why this answer is very, very crucial. Now, why are the rest of the answers wrong? Telling the patient to direct his concerns to the local medical regulatory authority may come across as dismissive and could escalate the situation further, right? So if you're a doctor who it comes across as you're always dismissing patients, this is nothing. No, that is not the approach the medical council wants to see in you. If you're going to join the medical community in Canada, there should be a lot of empathy. There should be a lot of respect for patients' concerns. Okay? And then reassuring the patient that his symptoms will eventually resolve might seem dismissive of his current concerns and may not be true, as permanent disability may occur in a minority of severe cases, right? So in no way do you want to come across as trying to dismiss somebody's concerns. No, in no way. So whenever you're dealing with a medical ethical issue, these are the things you want to pay attention to. And then as well, offering to immediately transfer his care to a colleague could be perceived as avoiding responsibility, okay, and may not address the underlying issues causing the patient's dissatisfaction. So that's also something you don't want to get yourself into, where you come across as shirking responsibility in the medical council exam. Don't do that. And they got this from the Canadian Medical Protective Association. That's the CMPA. There's a whole article they wrote challenging patient encounters, how to safely manage and de-escalate. And that is why, for me, I always urge you, please use the appropriate MCC materials. And today I'll take you through all the 5 materials you need for clinical ethics so you can use it for your studies. So you realize that when you go to the MCC objectives, there is a part, we call it legal, ethical, and organizational aspects of medicine. And under it, these are the 4 areas you need to master for your ethics. 1 is consent. Number 2 is truth telling. Number 3 is negligence. And number 4 is the legal system. These are the 4 areas you must master so far as the MCCQE1 exam is concerned. Okay, so if you need the MCCQE1 objectives, let me know. I will share the link with you. In fact, let me do that right away. If you don't have the objectives, let me know so that I can share it with you. Because doctors, please use the objectives as your guide. Use the objectives as your final word. If somebody is suggesting a topic, ask the person, is it in the objectives? If it is in objectives, study it. If it's not in the objectives, please don't waste your time. Don't waste your time on it. So these are the 4 areas you need to master so far as ethics is concerned. Okay? All right. Okay. Dr. Gregory says I should share. And Dr. Gregory can also send me a WhatsApp message. We have like a simplified version of it because this one contains about 440 pages. I'm going to share the link right away. But then we have simplified it and we've also classified it based on systems, okay? So I've shared the link. So Dr. Gregory, please, you'll see it in the comment section. You see it in the comment section right away, okay? Okay, yeah. And then for those who want like the MedCognito simplified version of the objectives, it's just 36 pages instead of 440. This 441 tells you everything in the objective. But if you want, okay, in cardiology, what are the topics to study? In respirology, what are the topics to study? In endocrinology, what are the topics to study? We have already done all those things. The medical council arranged it alphabetically, but we have taken all the various areas and grouped them because I know that is how a lot of doctors study. Okay, all right. So let's go on. One thing we have to understand is that doctors face difficult patient encounters. All of us do. I face them. You will face them when you start practicing, right? And it's about how to navigate them because each patient encounter has its unique thing. And that is why, for me, I really see that the Medical Council of Canada exam is a very practical exam. So what is happening in the question? This is not a medical management question. You can tell because the MCCQE1 deals with real world medical scenarios. It's not talking about something abstract that you need to memorize from a book, right? And in this case, you realize that the patient is dissatisfied and the patient feels harmed. Why? Because of the dyspraxia. And the patient is threatening legal action. And immediately it puts the whole question in the realm of communication, professionalism, and medical ethics. How do you communicate to the patient in such a difficult situation? So, one thing we have to understand is that when a patient is angry, dissatisfied, or threatening legal action, we have to prioritize 4 things. The first thing is that you want to focus on patient-centered communication. That's the first part you want to focus on. Patient-centered communication. The second thing you want to focus on is acknowledging the distress the patient is in. Okay? In this situation, the patient is having very bad pain after the humeral fracture. Maybe the way the fracture was set on, if you did a surgery, whatever it is, you need to acknowledge it. And then number 3, you need to find a way to de-escalate it. You need to find a way to de-escalate the problem. And number 4, you need to find a way to maintain the therapeutic doctor-patient relationship. These are the 4 things you want to do whenever a patient is angry. Focus on the communication. Number 2, acknowledge the situation the patient is talking about. Number 3, find a way to de-escalate the problem. And number 4, find a way to ask the patient, look, you may not be happy with this, but is there a way that I can still continue to serve you going forward? What the medical council does not want to see you do in your answer choices is to come across as a defensive physician. Hey, it's not my fault. No, don't do that. And as well, not managing the situation in such a way that then there is legal escalation. Another thing they don't want to see is you abandoning the care of the patient. And the last thing they don't want you to see is to give the patient a false reassurance. Oh, don't worry about this pain. It will go away. No. Always acknowledge the patient's pain. So let's evaluate the answer options. We've already looked at it, but I want to review it again. The first option said, tell the patient to direct his concerns to the local medical authority. This comes across as if you are being defensive. You're also being dismissive of the patient's concern. And it's like you're not doing anything to de-escalate it. Rather, you are escalating the problem, right? And this situation is like you are shutting down communication. And when you do that, you are rather making the conflict worse. In your MCCQE1, we are looking for ways to make conflicts de-escalate, not to escalate them. Okay. The next one is reassure the patient that his symptoms will eventually resolve. That's also wrong, because in that situation, you are minimizing the patient's concerns and you are ignoring the emotional distress that the patient is in. And it does not also address the dissatisfaction or the threat of legal action, because reassurance without listening is poor medical ethics, right? Oh, telling people, oh, your abdominal pain is nothing. Meanwhile, maybe there's something ominous happening. And then the 4th point is offer to immediately transfer the patient's care to a colleague. That is also very wrong, because it may be appropriate later if the patient says that, look, doctor, I don't feel comfortable after this situation. I don't think that with all the arguments we had, our therapeutic relationship can still hold, right? It may be a later thing, but don't come across as if you are trying to say, okay, go and look for another doctor. No. Find a way to solve the problem. Because immediately transferring the patient's care can be seen as you trying to abandon the patient and you trying to avoid responsibility and you not addressing the concerns of the patient. You not addressing the issue of the patient. So somebody just asked the question, and let me just take that question before we continue. Somebody says, Dr. Bimbola Adewolu 3720 says, what of case of suspected child abuse or assault? Of course, that one is a totally different ball game altogether. That one you need to report to the Child Protection Services. But this time we are talking about, maybe you did a procedure on a patient, maybe you offered a particular medication to a patient, maybe you gave some assurance to a patient, and later on down the line, it came across that, the patient was the presentation the patient had was something more serious than the false reassurance you gave, right? And then the patient is angry. How do you deal with it? That's what we are talking about. So the issue of suspected child abuse or assault is a different ball game altogether. And in fact, there's a class I did on our live YouTube channel. It's there. Please go there and review it. Okay, please go there and review it. Okay, so now you have to note something. When a patient is angry or is threatening legal action, the first step is always to listen. Listen to the patient. Number 2, acknowledge the issue. Number 3, explore the case with the patient. Don't go in with a defensive attitude. No. Number 5, don't defend, like don't come across as you are being too defensive, you are being dismissive, and you are just wanting to transfer the patient to someone else. No. Always listen and acknowledge what is going on. Now, let me add another twist to it. What if this difficult patient encounter is bordering on your personal safety? This time the patient, maybe let's try a question. Let's try a question on that. Let's try a question. So we've just dealt with dealing with the patient encounter, which is like benign, right? How to deal with it. Now we are going to look at another level where you have a 34-year-old man who presents to your office or clinic for follow-up. During the visit, he becomes increasingly agitated. He raises his voice and he states, "If you don't fix this today, you will regret it." You feel unsafe and are concerned that the situation may escalate. Which of the following is the most appropriate next step? Remember, this question is a bit different from the first question, where the first question, the patient just told you that, look, I'm not happy with what you've done with me, blah, 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 and because of that, I am threatening a legal action. This one, the patient is actually saying you will regret it. You don't know what the patient means by you will regret it. So what's the most appropriate next step? A, attempt to calm the patient and continue the visit to avoid conflict. B, ask clinic staff to restrain the patient while you complete the assessment. C, contact the police and provide only the information necessary to address the threat. And D, document the encounter and arrange transfer of care at a later date. The way the patient is speaking, it's as if something has happened and the patient was expecting you to deal with it and it was not dealt with and the patient is angry. Okay, so what's the correct answer? The correct answer is C. In fact, the correct answer is C. C, contact the police and provide only the information necessary to address that threat. Now, if you take a time and read that article that MCC got this question from, you will appreciate some of these things I'm talking about. Why are the rest of the answers wrong? Attempt to calm the patient and continue the visit. That is wrong because it is inappropriate when there's a credible threat. Always make sure that your safety comes before de-escalation. Your safety is important, doctor. We need you alive. We need you safe. We need you sound. We need you together. So your safety is very, very important. What about asking the clinical staff or the clinic staff to restrain the patient? That is also wrong because number one, that is unsafe. Number two, it is outside the scope of practice of the clinical staff. Most of the time, the people we have as clinical staff, they are like office administrative staff, right? You can't tell, that can be considered as assault, right? You can't tell someone to go and restrain a patient. No. Unless that person is trained. And even that one, we have various forms of restraint. Physical restraint, chemical restraint, right? Those things are there. Because trying to ask the clinic staff to restrain the patient could escalate and there's a risk of harm. And then Document and arrange transfer later. That's also wrong because it delays care. It looks like the patient is going through something. The patient says you need to fix it. And it does not address that immediate danger that the patient is in. So let's reason through the case. You realize that this topic is about, this second case is about threatening behavior. The patient is actually threatening you. Okay? And it also borders on your physical and physician safety. And sometimes it's even about the safety of the people you work with. And there's the risk of escalation. It can really, really go high. So once your safety is at risk, doctors, please remember, so far as your safety is at risk, it changes your priority. It changes your priorities. You must protect yourself. So in medical ethics, you have to understand that your safety overrides therapeutic communication. When a physician reasonably feels unsafe, and I'm using that word carefully, reasonably feels unsafe, they should not hesitate to contact the police. This is very, very appropriate. It is not like you're punishing the patient in any way, shape, or form. It is important to contact the police if you feel that your safety is at risk. Now, when you contact the police, you have to be very careful in what you share with the police. You have to share only what is necessary. That is the patient's name and the nature of the threat. Don't disclose the medical details to the police. And number two, if you follow these three things, it shows that you respect the patient's confidentiality even in the case of crisis. So don't go talking about the patient's diagnosis and everything with the police. No. All you need to do is, hey, 911, please, I have Mr. John Smith in my office. He's a 55-year-old gentleman who came into my office. He's threatening to do me harm. Right? That's all you provide to the police. Don't disclose the patient's medical details, his past medical records. No, don't do that. That is a breach of confidentiality. Even when your safety is being threatened, please make sure that you also protect the patient's medical records. Unless a competent court of jurisdiction is asking for that. Even that one, we did a particular class where we realized that don't just disclose the details or the information to the police. If you have called to court, you got to go to court with information sealed unless the court asks you to disclose it. Okay, so if a patient's behavior threatens safety, the correct next step is to involve police and share only minimum information required. Okay, someone is saying something here. Let me read it for you. Dr. Noah Lobo says, in my country, we rather take option A because many people are in cartels or know someone who is in it. After that, we transfer the patient. Okay, so let's go back to see what A was talking about. It says, attempt to calm the patient and continue the visit to avoid conflict. I get where Dr. Noah is coming from. But you realize that even if the person wants to do you harm, no matter how much you try to calm the patient, it does not really help. So that's why I want you to stick to Canadian ethical standards, right? So thank you very much for sharing that, Doc. Thank you so much. Okay, so I'm trying to reach a point where I want to drum it into your head. Doctors, please use the right materials for your exam prep. And so, number one, if you want to ace your ethics, there's this book. It's called Doing Right. Doing Right. This is the official book the Medical Council wants you to use. I'm going to share the Amazon link. You can order one right now. It is called Doing Right. This is the book that the Medical Council has stated on their website that you need to use for your medical ethics. It is written by Philip C. Herbert and Wayne Rosen. Okay, that's the first book I want to draw attention to. The next one is the CMPA website, the Canadian Medical Protection Agency, their website. I'm also going to share that. Please use that resource for your ethics preparation. Doctors, please don't go yet. We are not done with the questions at all. I'm just sharing the materials you need for the exam. The CMPA website. I've shared the link as well in the comment section. Okay. Number 3, we have what you call the CMA Code of Ethics and Professionalism. That is the Canadian Medical Association Code of Ethics and Professionalism. I'm going to send the link to you as well. Very important. Okay. It's a very, very important material you need to use for your exam preparation. These are all stated by the Medical Council of Canada on their website. And I'm just bringing you the direct link because many people go and everyone says, go and read Toronto Notes for Ethics. No, Toronto Notes is a very good book. But if you want to get the real source where, the Medical Council focuses so far as the exam is concerned, these are the areas. All right. Next, the Model Practice Standard for Medical Assistance in Dying. So when it comes to MAID, Medical Assistance in Dying, there's a Government of Canada website, and I'm going to share the link as well with you. Doctors, please use that resource. Make sure you've read everything there. It's about medical assistance in dying as well. That helps you to know what are the standards in Canada about medical assistance in dying. Okay, good. And then last but not the least is what we call the CMPA Medical Legal Handbook for Physicians in Canada. I'm going to share that as well with you. The Medical Legal Handbook for Physicians in Canada. So 5 things you need to know for your exam. Ethics. These are the resources the Medical Council wants you to know. For your ethics, remember, Medical Legal Handbook for Physicians in Canada. That's number 1. Number 2, Models Practice Standard for Medical Assistance in Dying. That focuses on MAID and all the rules around it. Okay? Who qualifies for it and everything. Number 3, CMA Code of Ethics and Professionalism. Number 4, the CMPA website. They even have some quizzes in there as well. And number 5, doing right. Doing right. Doctors, please, I want to know, can I proceed with the class? I just want to know, can I proceed with the class, or you want to copy the links first? Just type in the comment section, let me know. Let me know. Because you need to be empowered with the right resources for the exam preparation. Please, if you review these areas, and these are the areas I focus on in our MedCognito program. Okay, good. Now, the other thing is that yesterday night, we took a very, very important step in MedCognito because candidates were, struggling with, some candidates wanted a more user-friendly page, right? Some candidates wanted a more user-friendly page. So they asked that we do something about it. And yesterday we took a very, very important step. So now MedCognito has a new study platform altogether where you can actually track how much you've studied. So if you start a course and you are going into the exam and you've only studied 4% of the content on the page, you've not prepared for the exam at all, right? As you go through it, it will tell you, okay, click on complete. Because if you complete it, then it will tell you where you've gotten to, right? So as you go on, it helps you to calibrate everything. And all the objectives you need, everything is there. And we've classified everything under various systems. So when it comes to ethics, everything you need under ethics is there. When it comes to hematology, everything you need. So as you go, it helps you to know how far you have going in your MCCQE1 exam preparation. At the same time, if you go down, okay, this is what we call Med Bullets. Now, Med Bullets has been created as a unique thing on its own. So you can go from Med Bullets 1 all the way to Med Bullets, let me just check here for you. All the way to Med Bullet 316. Now, remember that every single Med Bullet contains 10 topics. So if you have 316 med bullets, that means you have 3,160 topics reviewed again. Now, this is what you need for your final exam. So if you are short of time, you can just plug into med bullets and just go through it, because that gives you, all the high yield stuff you need. Now, if you want to dig deep, then you go into the system by system thing. And then we also have what we call med drills as well. It's also there. In the portal, we are going to put a link there. You also have a question bank. So doctors, this is what you were asking for. And now we've provided everything for you. So if you go to the med bullets, everything is there. So in 5 minutes, you are going to complete med bullet 310. And med bullet 310 contains 10 topics. Then you go to med bullet 311. In another 8 minutes, 51 seconds, you complete 10 topics. That is how we've done it. So just wanted to bring you up to speed on what is happening in MedCognito right now. You can track your progress. You can do mock exams. You can use the question bank in there. You can do your med bullets. You can do your med drills. And also, you can attend the live classes, which happen every Sunday and every Thursday evening. Okay, the same platform. Now you can access everything on your phone and even track it on your phone as well. So doctors, great times, great times. And we finished the whole migration yesterday. And this all goes for a very, 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 very cool price. Okay, it goes for a very, 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 very cool price. And it's only $420 every month. Just $420 every month. Or if you want 6 months access and you want to pay one time, it's only $2,199. Yeah. Someone says it's a great innovation. In fact, a lot of the candidates are very, very happy because it's been a long time coming. And there's something else we'll be doing in the coming days. Very powerful. I'm not going to say it right now. I want to underpromise and overdeliver, right? So if you want to join us, please just go to the MedCognito platform and you can have access to whatever it is that we have on the page, right? And if you want to get it, I'm just sharing the page with you. If you want to get it, it's very simple. When you go to the MedCognito platform and you go to the exam preparation, you realize that there are various options for you. Various options for you. You can do the one-time $2,199 payment, okay? Or you can pay over 2 months. That is 1,150 Canadian dollars for 2 months, and you still get access for 6 months. Or you can pay over 3 months, $799 3 months, and you still get access for 6 months. Or if you want to pay month by month by month by month, it's also there for you. Whichever option you want, you can have it. So those who are asking me, yes, I'm sending the link in the comment section right now. It is available right now for you. Just click on it and then you can get into the program. Just click on it, you'll get into the program right away. It's an awesome night. We didn't sleep last night. We did a migration and I'm so happy about it. Okay, so doctors, take advantage of it. So let's get back to the ethics topic. Let's try some more difficult patient encounter scenarios. Let's do that. Based on that article from the Medical Council. A 52-year-old patient states angrily, "You rushed me the last time and I didn't care about what I was saying. Meanwhile, you believe the care provided was appropriate. What is the best next step?" A 52-year-old patient states angrily, "You rushed me last time and I didn't care about what I was saying. You believe the care provided was appropriate, but the patient feels that you rushed him through the encounter. What is the best next step?" A, explain the time constraints of the clinic to clarify expectations. B, acknowledge the patient's frustration and restate their concern. C, reassure the patient that clinical decisions were evidence-based. And D, ask the patient to submit feedback through the clinic's formal process. So I see some doctors going for B. Some doctors are also going for A. So some are going for B, some are going for A, some are going for B, and some are going for A. What is the correct answer, Dr. Rockefeller? Honorable Rockefeller went for B. The correct answer is B. You want to acknowledge the patient's frustration and restate their concern, right? In B, you realize that you are prioritizing sequencing. What do I mean by that? Even if the care you provided was appropriate, the first step is to acknowledge the patient's emotion. Mr. Smith, I'm very sorry that you feel upset about the care you got when you came in to see me. Look, doctors, I have a question. No matter how angry someone is, if you go in with that approach, at least the patient may still be angry, but he would have calmed down a little bit. And it shows you heard their concern. Because restating the concern will de-escalate the problem before the explanation. So, Mrs. Smith, I'm sorry that the surgery we did for your humeral fracture did not deal with the pain as you were expecting, and you are still in pain. You know, in this medical ethics thing, right, you have to understand that being right does not come before being heard. The patient wants to be heard. So please, hear the patient out first. That is the skill the medical council wants to see you demonstrating. You may be right, but please, hear the patient well. So A is wrong because it explains too early and it comes across as you are being defensive. C is wrong because it justifies the care without addressing the emotion. And let me go back and look at the option. C says, reassure the patient that clinical decisions were evidence-based. Fine. But the patient feels that he or she was rushed through the encounter. That is why in our NAC-OSCE program, one key thing we teach is what we call FIFE. F-I-F-E. How do you feel about this problem? What is your idea about this problem? How are you functioning? And what is your expectation? So, for example, this patient comes in and the patient says, you rushed me the last time and didn't care about what I was saying. The FIFE protocol teaches me that what is the feeling of the patient? The patient feels rushed. Even though you as a doctor feel that, oh, I gave the best I could for this patient, but this patient feels rushed. What's the patient's idea? The patient's idea is that they received suboptimal care. What's the function? If we have to direct it to the patient who had the humeral fracture, the patient feels that, look, I am still in a lot of pain. I can't do a lot. And what are their expectations? Because every patient encounter, the patient has an expectation. And the expectation is that find a way to help me so that my pain will go down. That is it. Right? So all the time, doctor, you may be right. But being right does not come before being heard. Always remember that in your medical ethics. Always remember that. Okay? Let's try another question. A patient nods, okay? They are nodding throughout your explanation of a complex care plan, but later demonstrates misunderstanding. Okay? But later demonstrates misunderstanding. Which approach best addresses this? A patient nods throughout your explanation of a complex care plan, but later demonstrates misunderstanding. Which approach best addresses this? A, ask whether the patient has any questions. B, provide written instructions using medical terminology. C, ask the patient to explain the plan back to you. D, repeat the explanation more slowly. I'm sure she's sitting in the exam, you go like, what kind of questions are these? I was coming to solve questions on pneumonia and the rest, and look at what Dr. Boni is asking me. Doctors, This is how, from the free questions the medical council provided, these are the clues I'm picking up. It's not all, serious medicine and hepatic encephalopathy, and no, those things are important. But these are the areas which will trip you if you've not paid attention to medical ethics. So I see some doctors went for A, that is, ask whether the patient has any questions. And then some also went for C, which says, ask the patient to explain the plan back to you. I think the verdict is on C, because you see, the patient is nodding through the explanation. When a patient is nodding, it's as if the patient understands everything you are saying. Later on, you find out that the patient does not understand. So what you have to do is to ask the patient to tell you in the way he or she understands the issue, and then you can fill in the gap. Now, let me listen to what one of the candidates is saying here. Dr. Rockefeller says, she demonstrates misunderstanding afterwards, so no need to ask to re-explain. I'll repeat. Now, Dr. Rockefeller, you can only repeat, or you can only repeat when you think that your explanation was not taken very well. But it could also mean that the patient understands it totally different, right? I don't know how to put it, but maybe someone comes to your office and you say, make sure you take your iron. I'm giving you an example. This is a joke, right? This has happened before. Make sure you take your iron, and then the patient goes home and picks a proper pressing iron. And he says, my doctor says I should take my iron. And the patient is holding the pressing iron in the hand, right? It's just a joke, but you realize that, look, in the clinic, a lot happens. In fact, there's this TV series called Dr. House or something, right? Dr. House, and a patient came in and the patient was saying, the patient has asthma and asthma is not being controlled. And Dr. House was asking, hey, tell me, how are you using your puffers? And the patient says, I use the puffers so well all the time. I use it. And Dr. House was like, okay, just show me how you use the puffer. Do you know what the patient did? The patient picked the puffer, like, because the puffer, you can press it and make shh. And the patient was like, shh. Then Dr. House was just watching this patient and was like, okay, I now understand what is going on, right? Instead of the patient putting the inhaler in the mouth, the ventilator inhaler in the mouth and pressing it, the patient was spraying the inhaler around as if he was putting on, perfume. So these are things, you'll be surprised. Like, patients come to us, we talk to them about medical stuff, and we think that they understand what we are saying. No. When a patient is nodding, it does not necessarily mean that the patient understands what is happening. Active confirmation of comprehension is very important. So you realize that even in your narcolepsy, someone says atasa. Yeah, atasa means the patient has just scattered the whole thing, right? You think the patient understands, but the patient does not understand anything. In narcolepsy, and that's how candidates do very well. The candidates who do very well, those of you who will be taking the narcolepsy, the candidates who do very well in narcolepsy, they have an approach. As they discuss the patient, okay, Mr. Smith, so the pain you are having in your tummy, we've done the investigations, we've done your complete blood count, it came back good. We did a CT scan, it came back good. The surgeon has evaluated you, everything is good. Mr. Smith, please, can you repeat what I have told you in your own words? And you realize that the patient then tells you everything. And as the patient tells you, you then have an opportunity to deal with any misconceptions and misunderstanding the patient had. That's the beautiful thing about this whole thing. So whenever you're explaining something to patients, especially in your narcolepsy, make sure that it is not a one-way conversation and that the patient is also giving you feedback. Okay, so teaching back avoids assumptions about literacy or language, because you know what? Sometimes the patient sitting behind you may not be as educated as you are. And you must allow the patient to tell you what they understand in their language, in the language they understand best. Okay, So now let's go to the next question. You need to ask a patient about sexual history during an unrelated medical visit. You know, like in recent times, the guideline is that you need to screen sexually active patients, like sexually transmitted infections, once a year, right? Now, the patient appears uncomfortable about the conversation. What is the most appropriate response? You need to ask a patient about sexual history during an unrelated medical visit. The patient appears uncomfortable. What is the most appropriate response? A, proceed quickly to minimize embarrassment. B, skip the questions unless the patient volunteers information. C, explain why the questions are relevant to the patient's care. And D, document refusal and continue without discussion. What's the correct answer? What's the correct answer, doctors? Good. The correct answer is C. Everyone went for C. Dr. Benedicta Glover, Dr. Rockefeller, Dr. ZVIKXDZUM. Everybody went for C. Right? Now, why? C talks about transparency. It talks about respect. And it talks about shared understanding. You need to explain intent, and it helps to preserve trust and autonomy. So, let me chip in. The reason I'm trying to chip in some Narcoski stuff, because in the Narcoski like this, if you have to discuss such a thing with a patient, you can tell the patient, Mr. Smith, I want to discuss something sensitive with you, and it's about your sexual history. Are you okay with that? Right? You ask permission. And then you gauge how the patient goes like, okay, sure, that's fine. But you don't go just asking, Mr. Smith, have you had gonorrhea before? Have you had syphilis before? When you do that, the patient will go like, it's like you're ambushing him, right? In Canada, we don't like that. You have to ask permission, especially when you are dealing with such sensitive life issues. Okay? Explaining the intent helps to preserve trust and autonomy so that you don't come across as you are just prowling into the patient's private life because you are a doctor. No, you don't want to come across like that. That is very wrong. Okay? Awesome. So next question. During a clinic visit. So these are all difficult patient encounters. That's what we are dealing with today. And the medical council wants you to master scenarios like this, right? So during a clinic visit, a patient repeatedly interrupts you and raises their voice. Which response is least appropriate? Least appropriate. A, pause and allow the patient to finish speaking. B, maintain a calm tone and simple language. C, interrupt the patient to correct misinformation. And D, avoid judgmental or dismissive language. Which response is least appropriate? Least appropriate. Least appropriate. Which response is least appropriate? Pause and allow the patient to finish speaking. Maintain a calm tone and simple language. Interrupt the patient to correct misinformation. And avoid judgmental or dismissive language. What's the correct answer? And the correct answer is C. The least appropriate, that is, what don't you want to do, is to interrupt the patient to correct their misinformation. No, let the patient speak. Pause as a doctor and allow the patient to finish speaking. Give the patient all the respect. Number 2, maintain a calm tone. Don't come across as if you are flustered. You are angry. Why are you speaking to me like that? No, don't do that. Number 3, avoid judgmental or dismissive language. So always keep calm. Don't interrupt patients. Okay, interrupting to correct the patient will escalate the conflict. Remember, dealing with Dr. Bernard Saika, dealing with ethical issues, you always want to de-escalate. You don't want to escalate. So if there's any answer option which escalates the problem. Please, you want to avoid it. You want to avoid it, okay? Do not exhibit self-control seeking behavior. Don't come across as if you want to control the patient. And why are the others wrong? Because, this question is framed in the double negative, the least appropriate, right? So you need to always watch the language which the question is framed. In conflict, control worsens outcomes and containment improves outcome. So find a way, to calm the nerves of the patient, calm the patient down. Okay, next question. A patient makes inappropriate remarks toward clinic staff. What's the best documentation strategy? Look, and the truth is that clinic staff take a lot of heat. The front desk people, please. So when you start practicing in Canada, please make sure you respect them a lot. Please. This is very important to me. Make sure that your clinic staff, you respect them. Make sure if you're working in the hospital, the hospital clerk, the ward clerk, the housekeeper, everybody, you respect everybody. In Canada, we respect everybody. We don't respect you because of your position. We don't respect you because of the work you do per se. We respect you because you are a human being. That is it. So, a patient makes inappropriate remarks toward clinic staff. Maybe they called, they want to book an appointment, and they are just insulting the patient. Or they walked into the clinic and they want to book an appointment, and maybe your schedule is booked, right? And the clinic staff tells the patient, and the patient makes derogatory remarks. What's the best documentation strategy? A. Document that the patient was hostile and threatening. B. Avoid documenting to prevent future conflict. C. Document factual behavior and quote the patient's exact words. D. Document only if a formal complaint is filed. So what do you want to do? And the answer is C. Document factual behavior and quote the patient's exact words. That's what you have to do. That's what you have to do, right? When you quote the patient's exact words and you document properly, you are being objective. You are being non-judgmental and you are being factual. Verbatim quotes help to reduce interpretation and protect all the parties involved. So that is something very, very important you want to take home with you, okay? So doctors, how to deal with difficult patient encounters, done. Remember, oh yeah, and doctor says it's also specific. Yes, beautiful. So that it's not like you are putting your words into the patient's mouth, okay? So doctors, as usual, your servant, Dr. Bruni, I'm here. Your friend, your brother, we are here to guide you. We are here to support you. We are here to walk by your side. As you know, we have done a yeoman's job in making your learning experience very simple by moving to a new learning platform. All has been done for you. All for just $420 a month for 6 months. Or if you want to get a discount, $2,199 for 6 months access, or $1,150 for 6 months access, 2-time payment, or $799 3-time payment for 6 months access. Doctors, the link is in the comment section. I'm going to post the link again. Click on it. Get in. Get studying with us. Tonight there's a class, so I don't want to keep you too long, okay? And we are going to keep this video on the live portal on our YouTube channel. There are so many other lessons we've done there. Go there, learn from it, watch it, enjoy it. It's been a wonderful day. My phone number is +1 306 891 5649. +1 306 891 5649. My phone number again, +1 306 891 5649. Thank you very much. Enjoy the day. Always learn how to de-escalate tough patient encounters. And don't forget that Dr. Bruni and the MedCognito team are here to guide you. Okay? We are here to guide you. All the best, doctors. Stay safe.